All right, we're going to get started on our lunch and learn for today. This is female HRT, safety and benefits. I am Sarah Wells, one of the nurse practitioners here at Joy Wellness Partners. So we'll go ahead and get started here. So just kind of to start with the basics, just to kind of give you a little bit of info about, what actually is HRT. This is hormone replacement therapy. So, of course, this is the replacement of hormones in the human body that are no longer produced. Of course, this can happen for different reasons. Typically we're thinking about menopause, but say a female patient has had a total hysterectomy and oophorectomy. She's no longer able to produce her own hormones. That's one incidence, but then also say, you have a patient that has gone into early menopause for some other reason. So there's so many different scenarios, I guess. So it's patient by patient, but so just a little background. HRT was discovered as early as the 1930s with the first FDA approved replacement in 1942. This became more widely used in the 60s and then entered the Women's Health Initiative, WHI, study, which was released and halted in 2002. This was like one of the longest studies being done about hormone replacement therapy in patients, in female patients, and it was showing this results of increased breast cancer, blood clots, stroke, etc. So of course we fast forward, this was a huge situation, it's a huge finding, especially in hormone related research. So fast forward 2 decades later, of course, now we have found the flaws that were actually in this study. And I'll just kind of cut to the chase. A lot of this, we know this varied depending on the type of hormones that these patients were receiving, their symptomology, their backgrounds, you name it, right? There was a lot of flaws, or a good way to put it. So anywho, fast forward, these were identified. We now know a lot more about hormones and their effects on the body, especially when it comes to synthetic versus bioidenticals. And so now, of course, HRT has become more widely accepted and used. Of course, this is a topic that I speak on pretty much every day, myself and the other providers here, that we try to vouch for hormone replacement and try to really support the findings that have been, researched. And there's still so much literature and research and data to be collected, but generally speaking, this is the most updated information that I have been able to find and what we practice based off of, especially here in the clinic and when we're working with especially more like complicated patients in the hormone realm. So generally speaking, this is just going to be a discussion on not only hormone replacement therapy, but more specifically bioidentical, or BHRT, bioidentical hormone replacement therapy. So question might come up of, especially for my female patients, or future female patients, wondering, well, can I benefit from BHRT or HRT? So this is just kind of a nice span of people who could benefit. So premenopausal females, even if you're dealing with scenarios or diagnoses such as PCOS, adrenal fatigue, low motivation or mood, anxiety, depression, fertility issues, you've got poor recovery, poor recall, so that brain fog type picture, insomnia. These are just some of the common things I think that we hear of here, of course. And commonly, I hear my premenopausal females, which just for, as I hear stated later, that perimenopause starts quite early in females and can last for a very long time. So those fluctuations in hormones really actually start quite early on. And so those symptoms can kind of manifest in different phases. And so it might be that my lady has just come in and she says, I'm just not myself anymore. My primary care won't even check my hormones, or, they say everything looks fine and it's just what it is. It's just my hormones, and they don't ever really get this deep dive into what is happening and questions some of their questions, at least, maybe not all of them, but at least some of these questions should be answered for them. And so that's what we do. We try to dig in, and these are just some of the common scenarios that we see. Perimenopausal females, of course, when we start digging into that chapter of life where that that signaling from the brain to our sex organs to those ovaries, maybe that's starting to kind of check out. Maybe those ovaries are starting to not produce as much of the hormones. So when we start having this difference or this change in signaling for whatever the reason, then we start experiencing these symptoms, and they can be things such as hot flashes, those periods start getting a little more irregular, mood swings, vaginal changes, so maybe it's pain during intercourse, dryness, itchiness, that really can't be explained by any type of other diagnosis, joint pain, decreased libido, which is for females, and I say this a lot in my consults, but for females, our libido is linked to a million things. So, our libido is up here. And so it's emotional, it's physical, it's mental. There's so many components to it. If we're distracted by other things going on in life, our libido can be affected. So this doesn't help when we have on top of that we have this fluctuation and roller coaster of emotions and hormones at the base of it, right? When we're having these changes. So it can be worsened by that. Urinary symptoms, weight gain, memory changes, brain fog, night sweats, insomnia, irritability. These are just some of the typical things that, that perimenopausal window can look like. You can have maybe the bleeding has changed, that your pattern of bleeding is a little different, or, you typically had very regular periods and now they're a little more irregular and they're spacing out. Those type of symptoms, or even commonly I hear my females, they never really had PMS symptoms, and now we're starting to experience more of this moodiness, irritability, and fluctuations in mood and emotions that they're just not used to. Can kind of fall in this category this time. And then of course my postmenopausal females. So once we've hit that mark of that FSH has kind of hit its peak, those ovaries have essentially checked out and they're like, I'm done, no more hormone production from me. That's when you can see a lot of these same, it could vary, but a lot of these same symptoms as discussed above, but then also just with potential worsening, our adrenal glands also play a large part in our hormones and our hormone health. So there's so many components to it, but one other thing though, just when we start losing our estrogen, we also have this increase, start losing estrogen, you have decrease in bone mineral density, and then you've got this increased risk of osteoporosis, so premature fracture, which is not at all what we want. So just a little factoid here that women lose up to 10% of their bone density within the first 5 years after menopause, and then with of those two women, 1 and 2 women older than 60 experiencing at least one fracture due to osteoporosis. So those are stifling numbers. So something that we need to be aware of for sure. And this is just kind of my hot flashing females can really associate with this. And so hot flashes, of course, can be really detrimental and life-changing for our patients. And, there's even patients, myself, I even deal with issues with estrogen production and my progesterone, and I too deal with hot flashes, and they're minimal and they are not fun. So I can only imagine what my ladies who are actually experiencing full-blown hot flashes frequently throughout the day and then disrupting their sleep at night. I can only imagine their quality of life, because when I'm experiencing them, the minimal times, the few times I have, not fun. So, okay, so some common misconceptions here. Estrogen causes breast cancer. This is like one of the most debated, feared topics, right? It can be quite intimidating, not only as a provider that deals with hormones, but also as a patient to say, I'm scared of this. How am I going to be safe? So there are studies that now show no direct correlation with estrogen replacement therapy and breast cancer, with one study showing, of course, a not statistically significant 0.6 risk in women taking estrogen for greater than 10 years. Now, this study, of course, be mindful, this was performed the study was based off of synthetic forms of estrogen and progesterone, so as known as like progestin. So that's just another kind of educational point that we really dig into when we're in these consults is that there is a large difference in synthetic estrogen and progesterone versus bioidenticals. So bioidenticals are derived from natural sources, whereas synthetics, of course, are synthetically created and more of a chemical that is synthetic. So molecularly speaking, they are different. So significance, of course, should be placed on genetic testing, risk factors on a very patient-to-patient basis, and hormone metabolism testing is also quite beneficial. So Dutch testing, for instance, is very helpful for us as providers, and we encourage it as often as patients are willing to participate and are able to do this. It's quite helpful for us to really give more of a safe, I guess, picture of how we're delivering these hormones. But generally speaking, so much of what we do is based off of the intake. It's based off of asking questions, assessing these patients. So there's so many factors that really go into it. And of course, we'll talk a little bit more about this a little bit later in the presentation. Another one common misconception: my doctor says I cannot have estrogen or progesterone because I had a blood clot in the past. I've had a few patients actually that have dealt with this. I've had patients who had strokes in the past for different reasons, etc. So of course, it's clinically concerning for me as a provider in how I practice. It's concerning to place a female on with a previous DVT, of course, depending on the etiology, on a synthetic estrogen or progestin replacement. But again, the etiology of the DVT is imperative, and it's all comes down to the responsibility of the provider to really obtain the thorough medical history and med rec, etc. But estrogen can affect several aspects of liver metabolism. So when we're talking about oral estrogen or an oral synthetic progesterone or progestin, not micronized progesterone that we like to use. So synthetic estrogen, progesterone or progestin, that is taken by mouth, swallowed. It goes through that GI tract through that first pass effect and then is synthesized and metabolized through that liver. Your liver is where your clotting cascade occurs in your body. So when we start talking about blood clots and things like that, that's where it occurs, right, where that cascade kind of kicks off. And so the concern is taking these hormones directly and them going through that first pass method and through that liver. That's where that increased risk of blood clots comes in, or DVTs, as you might hear them called. Bioidentical, just another fact here that or kind of how we practice, right? So bioidentical estradiol or E2 and the micronized progesterone do not fall in this category because they are not being taken by mouth. One, our micronized progesterone is just placed under the tongue and is absorbed sublingually. And also it's micronized progesterone. It's not a synthetic progestin. And then also E2 is administered transdermally or intravaginally via cream or sub-Q via pellet, which does not affect that liver clotting cascade thus far that we've found. And there is no proven increased risk of blood clot by utilizing these therapies from any research that we have been able to find. Hormone replacement will cause a stroke. This is a near and dear topic to my heart, as I used to work in neurocritical care and took care of a lot of, stroke patients for different, they all occurred for different reasons, but just so that for a little educational tidbit, there's different types of strokes, right? You have 3 different types. You have ischemic, hemorrhagic, or a TIA. So it's either tissue is dying for some reason, there's bleeding where there shouldn't be. And again, you could have an ischemic that turns into a hemorrhagic, but that's just digging a little extra deep. Anywho, or you could have a TIA, which is a transient ischemic attack. These all can occur for different reasons. They all have a different etiology sometimes, but there are so many risk factors that go into this. And so when we're talking about the safety of hormones, these are other things that we as providers have to keep in mind too. High blood pressure, diabetes, that's insulin resistance, high cortisol or high cholesterol rather, atrial fibrillation, just age, family history, ethnicity. There's so many different factors that go into one person's health status and risk of different events occurring that all of these things could actually be going on in one person, all of these diagnoses. And so by me adding in hormones, that is my, and our responsibility as a providers to really weigh benefit versus risk. And for us, the safest way to replace these hormones that we have found is to do this in a bioidentical format. And so these transdermal natural estrogens and progesterones micronized. And so there was a follow-up study to that Women's Health Initiative with the conclusion, this was published in 2007 by Marianne Konakio, that increased the conclusion of the increased VTE risk, or that blood clot risk. This was the Esther study that concluded oral but not transdermal estrogen is associated with an increased risk of blood clots, just what I was kind of saying earlier. Additionally, there was another meta-analysis looking at 8 observational studies and 9 randomized control trials published in 2008 by the same author that showed oral estrogen increases the risk of VTE by 2-fold or 3-fold, no significant risk among women using transdermal. So just another, we like facts and we like science. So here's some evidence behind what we're doing. And then additionally, when we're talking about pellets, these sub-Q pellets, of course, they're controversial when you talk to maybe more of a Western medicine-based provider versus someone who is more in this functional and integrative medicine realm and naturopathic format. But there have been no randomized head-to-head trials comparing transdermal delivery with sub-Q pellets. However, there was a 7-year retrospective study in which a lot of pellets were performed in over 400,000 patients. And the overall continuation after 2 insertions was about 93%, with the overall complication rate being less than 1%. So generally speaking, pretty low risk, right? There are, of course, different complications that can happen with these sub-Q pellets, but typically it's more of a local issue of the wound healing itself versus other problems. And so this is just kind of a little, after thorough investigation of a lot of research, it's discouraging to see for every 10 articles I looked at, there was maybe 1 or 2 that were in support of more of a bioidentical and compounding, going through compounding pharmacies and things like that. It's just quite difficult to find the proving evidence, and that is for different reasons that I will not get into on here. But anywho, it's discouragingly, there's limited data and research on the actual increased risk of developing any type of cancer specifically related to bioidentical hormone replacement. Most studies, of course, that are trying to prove that these things are not safe are also referencing the WHI study and not making a point to clarify, actually, a lot of this was disproven later. And so that just kind of has me question as a provider trying to find good evidence, I question anyone who's going to quote and still rely on this study when it's been shown that had many flaws. So, that's that. Comes down to the fact, again, it's just the responsibility of us as providers to weigh risk versus benefit and give our patients the safest care we possibly can based on what we know and what research is available. And then I just wanted to make a little note. There's just some interesting information here when we start really digging into breast cancer risk. And so BioT, which is the pellet pellet company that we use, this is BioT's breast cancer and hormone receptor model white paper monograph, clinical evidence update. I'm just going to read you a little snippet from this. So speaking to the BRCA1 and BRCA2 mutations, there are several genetic mutations that increase the risk of developing breast cancer, which I kind of discussed a lot of there's modifiable risk factors, right, when it comes into that. But then there's also a genetic risk. Of course, we realize this. Genes are the basis of everything that goes wrong in our body. So probably the most well-known and reported are on mutations of BRCA1, BRCA2. These proteins 2-hydroxyestrone are involved in DNA repair. With either of these genes mutated or altered, such that its protein product is not made or does not function correctly, DNA damage may not be repaired properly, right? So if you've got this DNA mutation, some type of damage or an insulting factor is maybe placed in the body or the body's exposed to, that repair that should occur to that DNA after those type of things can't really happen when you have these type of mutations. So as a result, cells are more likely to develop additional genetic alterations that can lead to cancer. Women without the BRCA mutation have a 12% lifetime risk of developing breast cancer, and the average age for developing breast cancer in BRCA negative women is 61 years old with mutation in the BRCA gene. The incidence of breast cancer increases 60 to 80%, and the average age of development decreases to 42 years old. Patients with BRCA1 and BRCA2 also have a 20 to 40% chance of developing cancer in the same or contralateral breast in the years following diagnosis. And of course, this is all referenced at the end of this presentation. But it comes down to genetic screening is quite helpful. But generally speaking, this is specific to Biote's stance on hormone optimization in relation to breast cancer, that evidence supports the use of Biote method of hormone optimization to reduce breast cancer. The risk of developing breast cancer has been shown to be increased by elevated endogenous estrogen levels. In addition, androgens have been shown to counteract the proliferative effects of estrogen and progesterone in mammary tissue. Breast tissue from pre- and postmenopausal women also demonstrated the inhibitory effects of testosterone and breast cell proliferation. In patients with the mutated BRCA gene, there are almost no progesterone or beta receptors. So when we kind of start going into this is delving a little deep, but generally speaking, when we start talking about, where these cancer cells are and, different receptors that these hormones are working on, it's just helpful to kind of understand a little bit of the fact that, genetics play such a large part in a lot of this. And I even dig into this in my consults with my patients when they say, well, why am I having these symptoms or those symptoms? Or, my friend doesn't have this and da-da-da. And, or, I'm taking this hormone, but I don't feel different. And my symptoms are totally different. And it's just this way or that way. And all of this stuff comes down to genetics. It comes down to the way you metabolize your hormones specifically, right? So when we talk to patients in these consults and when I'm really working with especially my female patients, so much of this care it can't be cookie cutter. It cannot be just straight across the board. This is the answer for everyone. And so that's kind of what we have been provided, just generally speaking in medicine. We've just been provided this cookie cutter approach to trying to control hormones, and that is not the answer. It takes time, and it takes, listening, and it takes understanding how things are metabolized, how these hormones are metabolizing in each patient. So that's all I'll say on that. Sorry. And then also, this was just an interesting fact that I found by Dr. Donovitz. It was just a statement that bioidentical hormones are not regulated. The statement that bioidentical hormones are not regulated is inaccurate. So there are some claims, of course, like I was saying, the articles I'm finding a lot online, that compounding pharmacies aren't regulated and they can do whatever they want, and there's no regulation, and you're just receiving whatever. That's not true. These are pharmacists. They know what they're doing. But also, there currently exist long-standing regulations at the federal and state levels. The Drug Quality and Security Act in 2014 gave the FDA additional powers to regulate compounding pharmacies, including establishing the requirement of compliance with current good manufacturing practice. So this allowed for improved testing and manufacturing process, assure purity, potency, and quality testing, in addition to improved sterility of protocols. I mention that because, of course, we like to use compounded creams in our compounded micronized progesterone, and we have patients who really love this topical application as an option. So I just wanted to touch on that a little bit. And then just kind of now off of all the research and onto the benefits. So quality of life. This is, of course, to quote Peter Attia, who loves to really now speak on health span versus lifespan. Of course, lifespan is important. We want to all live as long as we possibly can. But our quality of life during that time that we're living is equally as important. So these patients, especially my peri and postmenopausal patients, who their quality of life is so affected by these symptoms, by the goal is, right, so for benefits, is that we can reduce these vasomotor symptoms. And so, for instance, vasomotor meaning hot flashes, night sweats, palpitations, migraines, dizziness, chills, those troubling, life-altering symptoms. I had one patient who literally was having a hot flash every few minutes, all day long, every day, affecting her sleep, affecting her mood, her energy. I mean, it just trickles down. You think about missing out on sleep for just one night, much less every night, all the time because of this. So it really affects quality of life. Other benefits: improve cognition, energy, recovery, sleep quality. Just another fun little factoid that we have as females, and I try to explain this sometimes to ladies, and they're like, "What? That's crazy. I thought just men need testosterone." But we actually have 9 different androgen receptors or essentially 9 different systems with androgen receptors in our female bodies. So our brain, breast, fat, muscle, bone, skin, blood vessels, heart, glucose, insulin metabolism, and vagina. So you can see that we have having that many different receptors. You can tell that, testosterone can be quite beneficial, testosterone, estrogen, and progesterone, all cardio, brain, and breast protective if used correctly. Also improved libido, vaginal dryness, that painful intercourse because of that vaginal dryness. So the benefit of maybe rekindling this intimate relationship with your partner that has just kind of maybe fallen by the wayside a little bit. Not only are you experiencing the emotional ups and downs, but then also, like, physically speaking, it's painful. It's not fun. It's hard to connect when all that's going on. So and then also lean muscle mass. So testosterone works by pulling water into muscles to help them build and grow. Ideally, this helps your lean muscle mass, which muscle burns fat. So if we're someone who is active and really building on those muscles and that lean muscle mass, which is very important that you maintain, especially as we're aging as females, we start losing the ability to even build new muscle as we age. So it's quite important to maintain what we have and keep working towards building as much as we can to protect our bones. But also, it's helpful to have that muscle mass because that's what helps us continue to be able to burn, especially some of that stubborn belly fat and body fat. Let's see. And then also, cortisol management. I do have a lot of patients who they're just like, go, 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 go. They're not sleeping well. They're not allowing themselves time for recovery. They're not giving that brain downtime. The brain fog is terrible. So I like to say cortisol management, just as it's related to increased energy, throughout the day, working energy, but then it's mostly because of the sleep regulation benefit that they're getting. So if we can regulate that testosterone, regulate that estrogen, and replace it if we need to, kind of regulate that progesterone, overall quality of life should improve, mostly because your sleep's going to be exponentially better. And then also potential additional relief of hot flashes that have not been relieved by traditional HRT. So there are some benefits of that testosterone in hot flash management, as well as the progesterone. So it's not always just that estrogen is quite low. It could be a component of both also the progesterone and their testosterone. And so I'm wearing my pink too, just to signify that October is Breast Cancer Awareness Month. This is such an important month, and it's quite near and dear to my heart from losing a family member to breast cancer, multiple family members. So so the awareness is important. Make sure you're getting your mammograms, etc. But let's talk a little bit about breast cancer. So Dr. Scott with A4M has provided some phenomenal information here, and I know it's a lot of kind of science here and research, but it's just essentially, I'll run through some of it just to kind of give a little bit of a rundown of the safety and efficacy of the hormone replacement that we like to do. So just a couple facts here of the risk of breast cancer related to hormone therapy use is quite low. The estimates indicating a rare occurrence, again, being less than 1 additional case per 1,000 women per year of hormone therapy use, or 3 additional cases per 1,000 women when used for 5 years. The type of hormone therapy, duration of use, regimen, prior exposure, and individual characteristics, of course, contribute to the effect of hormone therapy, which is what I've kind of already been discussing. Every patient is so individual, so there is no cookie cutter answer to any of this, and that is the important part of getting in here and sitting down with us and really digging into your health history, toxin exposure, things you're doing daily that could be affecting your hormones, etc. Breast cancer risk, thus women should be counseled about risk versus benefits, with focus on risk being similar to that of a lot of the modifiable risk factors that are going on now. So smoking, obesity, sedentary lifestyle, nutritional intake, the quality of food that we're eating. Generally speaking, the quality of the food that we have, especially in the United States, isn't really that great. So even the organic label, there's still some pesticides and things that can go into that. Those things can affect our hormones. So being aware of those things and exposure to toxins overall, chemicals that you're using every day, or maybe you work in a job that you have a very high chemical exposure. So a lot of that stuff plays into it as well. Observational evidence suggests that hormone therapy use does not further increase risk of breast cancer in women that are at high risk because of family history or after and bilateral salpingo-oophorectomy or for BRCA1 or 2 genetic variants. Systemic hormone therapy is generally not advised for survivors of breast cancer, although hormone therapy use may be considered in women with severe vasomotor symptoms, as we were discussing earlier, those hot flashes, night sweats, issues with bladder control, that are unresponsive to non-hormone options, which, of course, share decision-making with their oncologist. And then for survivors of breast cancer with a genitourinary symptom of menopause, this low-dose vaginal estrogen therapy, so that topical or intravaginal E2 or a combo like Biest cream can help with these symptoms. Let's see, may be considered with their oncologist. But so we always like to, in an integrative approach, I want the input from other providers. Of course, that's how we should all be working, is together, not against each other. So I want the input of my doctor, of my patients, their cardiologist, their urologist, their oncologist, whoever it is that's involved, to really build a safe plan for the patient. And then regular breast cancer surveillance is advised for all postmenopausal women with recurrent breast cancer screening with current breast cancer screening guidelines, including those who use hormone therapy. So just because we say like, oh, yep, we're good to go, it doesn't mean we shouldn't continue our traditional screenings, right? And looking for things, of course, your mammogram, your breast self-exam. These are all still very important and should not be negated. Okay, now to the routes. So for patients who are new to hormones, or if you're just kind of dabbling, curious, there's different routes, especially that we offer here. So subcutaneously, we can place these pellets in your little subcu tissue. So you've got your skin, and then you have subcutaneous tissue, and then you have muscle that sits below that. So that little subcu fat pad, little tissue, we can place these little slow release pellets in the skin. These are bioidentical hormones. The benefits of these, they are low maintenance, so more of like a slow release. They last from anywhere from 3 to 4 months on average. Reliable dosing, delivery, check-ins with a provider. I feel like maybe more frequently than with the creams. We still chat, yes, but I feel like at least I'm seeing my patients more frequently in person whenever we're doing pellets, and we can, it's a nice time to check in. Okay, how have you been feeling? Anything, have we checked that thyroid in a little while? Are you still feeling okay? And, what's changed in life? Is your stress worse? Things like that. So there's just a nice opportunity for check-in. Some of the downsides, just the procedure complications or the risk of, right? There's always a small risk of any type of invasive procedure, that there could be an infection, scarring, etc. And then there's minimal downtime for healing, but some patients are quite busy or have very physical jobs that require them to really be active, and it's difficult for them to rest. So for my females, 5 days, 3 to 5 days, really 5 days of just no glute heavy exercises, things like that. So, that's why we like to offer a different routes, is that there's no cookie cutter answer for any patient. It's very patient to patient, but pellets are wonderful way to manage a lot of these hormone related symptoms. And after, sometimes we hit it right on the money with the first pellet, patient feels great, that's it, we just continue on. Sometimes it takes a couple different pellet procedures, a little bit of time over months to really get things regulated. That's expected. These things have been going on throughout your whole life, and these changes have been going on just progressively. So it's never going to be an overnight fix, but we definitely can improve quality of life significantly, sometimes just with a little bit of extra information and care and talking and working through some of the ups and downs. But definitely pellets. I have so many pellet patients who have just can't say enough about the life-changing experience that they have with them. And then there's a topical option or intravaginal option with creams, which are also bioidentical. They're compounded bioidentical creams. Benefit of this is that the patient feels a little bit more in control and comfortable little more customizable for the provider. So for instance, I could add in, if I feel it's, if we've measured DHEA and that's quite low, progesterone intravaginally, just to give that little added benefit to that tissue, et cetera, that I can't really do with pellets. And it depends on if the patient's, a challenging, what I call challenging metabolizer. If this is a patient who sometimes we say they kind of eat through testosterone or estrogen, one of the two more, right? So that patient, for instance, who was having these hot flashes more frequently, we had to be a little more aggressive with her estrogen dosing. It took a little time, but we finally got her there, and that's that, right? But some patients are very sensitive to even just a small amount of estrogen, so it just varies. Negative to the cream, or downside, I guess, just, if you have to weigh your options, absorbability is variable and it does require a daily application. So just keeping that in mind. If you're someone who maybe you have terrible brain fog and you're not going to remember to apply your creams, then pellets are definitely going to be a better option. Just like to work through that with patients when we get there. But and then another option is sub-Q or intramuscular injections, and this just applies to testosterone strictly. So if we're someone who we're only doing testosterone, and it's actually more recently being found that sub-Q actually might be a better option, although it could be a little more painful. So verdict's still out on that one. But positive to this, control of dosing. So, we do 2 split doses twice a week typically. We split the dose just depending on the patient and their symptoms, but we'll split that dose up so that they're not having that roller coaster effect. The downside, of course, being these are frequent injections. You're poking yourself twice a week. It is a synthetic option versus bioidentical. So that brings me to the memberships that we have. So option 1 is that you sign up for upfront a year of coverage. That is $24.97. Or option 2 is you can opt for more of a manageable monthly payment of $249, a minimum of 1 year of commitment. And in our October special, you can opt for the monthly option and get 1 month free. So it is important that you do try to do this and book and take advantage of this by the end of the year, by 2024, to lock in the prices, because they are subject to change in the new year. So keep that in mind. Now is the time. And so what you get with these memberships, and this can also be found on our website, but this membership includes a comprehensive initial assessment. Of course, just all this jibber jabbering I've been going on about of these assessments and these consults that we have with patients, especially when we're first getting started. There's a lot of questions. There's a lot of kind of coaching through things, talking and really digging deep and getting to the bottom of things. That's this comprehensive initial assessment. And then, of course, you get this personalized hormone therapy. You can choose from the variety that I've just talked about. And then, of course, it includes this DEM supplement. So as we were talking about different metabolism of hormones and things like that, and then also other risk factors, so like liver health, for instance. Our liver is the main metabolizer of our hormones, so that plays a very large part in how our body is handling these hormones, how it's kind of synthesizing these hormones, and the effects that that's causing on our body. So we also always pair our testosterone replacement with DEM, which is a natural estrogen blocker in a way, but what it does is help to prevent any of that aromatization in the body from the testosterone into the estrogen pathway. And then, let's see, and then there's also a post-treatment follow-up that is included. So this benefits the patient, of course, just with ongoing care and post-treatment lab work and consultations, just as I was kind of saying. And just to say that, life is good. Of course, we all have things going on, and we are living it, right? Life is lifing, and we're going along with it, and it's great, but it could be that much better with the hormones regulated. So yeah. Okay, guys. Well, thanks for your time, and we hope to see you in here.
Thanks for watching. I'm Carol Joy Bender, the founder and nurse practitioner at Joy Wellness Partners. If you found this video helpful, give us a thumbs up. Please subscribe also to our channel, and share this video with someone who you think could benefit from it. You can also learn more information about these services by clicking our link in the description below. You can also leave a comment to let us know what content you'd like us to put out next week. Thank you so much for being a part of our community, and stay along with us for enhancing wellness in our world. See you next week.